So we see many, many different types of patients in the cancer center, but probably one of the most common conditions we see, both in the hospital and as outpatients, is anemia, or not enough red cells. Now, anemia is a huge topic, as I hope you appreciate after my little talk today. So I'm not going to be covering everything. I'm just going to be covering a few of the more common causes of anemia. This slide, I'll show a lot of pictures during the next 20 minutes or so. These are red cells, and anemia is not having enough red cells. Anemia is often diagnosed when someone gets a blood test done. This is a complete blood count, or a CBC, which is the most common test done. And when you have a CBC done, there are a number of different parameters in your blood that are looked at. One is the white blood cell count. White cells fight infections. Another is a platelet count. Platelets help your blood clot. And the third one is hemoglobin, or hematocrit, which is a measure of how many red cells you have. So when we say someone is anemic, that means that the hemoglobin or hematocrit is low. Now, the first thing we do when we see a patient with anemia, or someone who has anemia, is we do a history. And that's essentially the first part of any good medical visit. As you all know, I assume everyone here has seen a doctor. So we look for symptoms of anemia. Red cells carry oxygen throughout the body. So if you don't have enough red cells in your body, you don't have enough oxygen going to organs in your body, including your heart, your brain, your muscles. So people will have fatigue. They'll have pallor. Now, there are many reasons why people can look a little white, have some pallor. The body tries to compensate when you don't have enough red cells by speeding up the heart rate. And most importantly, exercise and tolerance starts to go down. So people will say, I used to be able to walk 8 blocks. Now I can only walk 3 blocks. I used to be able to go up 2 flights of stairs before I got tired. Now I can only go up 1 flight of stairs. We also ask for anything that makes the fatigue worse or makes the anemia worse. We ask for family histories of anemia and ethnicity. There are certain anemias that are inherited since childhood or since birth, and we're not really going to discuss any of those today. We also ask for other medical conditions, any chemotherapy or radiation, and we'll discuss why that is, and importantly, medications. All of these can cause anemia. And trying to figure out why someone has anemia is a little bit like a detective story here. After we do a very good history and a very thorough history, we do a thorough physical exam. We look for pallor, fast heart rate, if a person is yellow or not, whether or not they have a big spleen, big lymph nodes. The fingernails can have certain findings suggestive of anemia or causes of anemia. So really a very thorough physical exam is the next step. And then we do a bunch of blood tests. And there are many blood tests that we can do to try and figure out what is the cause of anemia and what's the next step, how do we approach it. The ones I'm going to discuss a little bit today is looking at the blood under the microscope, and I'll show you how that can be so important in finding out the cause of someone's anemia. We look at iron studies, and we'll discuss a little bit how low iron can cause anemia. We look at some vitamin levels. Low vitamin levels can also cause anemia. And we look for something called erythropoietin. It's a hormone that circulates around the body, and we'll talk a little bit more about why we look for that. But we do all these tests. It's too much to get into now, but all these tests mean something to hematologists. And there are actually even more tests that we can do, which we're not going to get into right now. Sometimes, and we'll look more to this, in order to really figure out why someone has anemia, we have to do a bone marrow. And this is, I say, the dreaded bone marrow exam. I don't know how many people here have had bone marrows. I had one myself. I volunteered for a bone marrow from a first week intern, someone who just graduated from medical school. And I wanted to see what it was like. And we also donated the bone marrow for research. It wasn't as bad as I thought. The first thing is the hip bone in the back here is numbed up with a lot of lidocaine. And then a needle, a little bit bigger than the needle that we take blood from, is placed into the hip. Some bone marrow is sucked out and put on slides. And then with another needle, a little piece of bone is taken off. And all those are examined under the microscope. And we'll see some bone marrow pictures today, too. This is essentially what the bone marrow can look like grossly. In this first panel here, you see the bone marrow biopsy. So this is a piece of bone that's been decalcified. And these little cells here are blood cells that are found in the bone marrow. When we suck out some bone marrow, or I should say aspirate is the kind of gentler, more scientific way. When we aspirate some bone marrow, we look at the slides, the cells under the microscope, and all these slides can tell us how are the cells deficient in something, are we missing vitamins, is there a problem with the bone marrow, and that's why someone's anemic. So essentially, there are two causes of anemia. Globally, there are two causes of anemia. And us, the hematologists, as you'll see, Bruce can attest to this, are simple people. We're simple country doctors, as one of my professors used to say. You can either not have enough red cells because you're not making enough, or you're destroying them too quickly. That kind of makes sense. And today we're going to mostly talk about not making enough red cells. So there are many reasons why someone cannot make enough red cell. There are literally hundreds and hundreds of reasons why someone could not be producing enough red cells. Some of those are not specific to red cells. In other words, for some conditions, you will also not make white cells. You will also not make platelets. And some of them are specific to red cells. But again, we're simple doctors. And I think there are really, if you really hone it down, there are 4 things that are required in order to make red cells. First, you need the nutrients, the building blocks to make red cells. This includes iron, vitamin B12, and another vitamin called folate. Second of all, you need hormones to make red cells. Hormones, you have many different hormones in your body. One hormone makes red cells grow, and that hormone, again, is called erythropoietin. Third, you need space in your bone marrow to make red cells. And when you don't have enough, if your bone marrow is full of not bone marrow, but full of infection, or full of scar tissue, or we've seen cases where it's full of cancer, you may not be able to make red cells. And fourth, you need a healthy red cell progenitor, a precursor, in order to make the red cells. We'll talk a little bit more about that. So let's talk a little bit about iron, because my mother says when someone's anemic, oh, you need more iron. So for a lot of people, when they think about anemia, they automatically think of iron deficiency. But as I've hopefully told you already, there are many, many, many reasons for being anemic besides having low iron. That being said, the most common cause of anemia worldwide is iron deficiency. We absorb about 1 milligram of iron a day. Things that can increase iron absorption is vitamin C or anything that's acidic. Good sources include vegetables. Eat your vegetables, but mostly iron in meat. So one thing that we ask when we see someone who's anemic, and specifically someone who's iron deficient, we'll ask that person, what's your diet like? Are you a strict vegetarian? Do you get spinach? Do you eat any meat? And there are some things that can, like tannins in tea, which can decrease iron absorption, but that's relatively rare. We lose about 1 milligram of iron daily, and that's usually through our gut. We lose some skin cells, we lose some gut cells, and those cells contain iron. And there's really so we absorb 1 milligram of iron daily, and we lose 1 milligram of iron daily. And so if your losses exceed your intake, you become iron deficient. Usually, for women, it's extremely common because of monthly periods. However, if we see iron deficiency in a woman who is no longer having her periods or who's been on birth control pills, or in a man, we really have to worry about blood loss in the gut somewhere. And although it's not always the case, we really have to rule out colon cancer, which is relatively common, as a source, or colon polyps, or precancerous in the colon, or bleeding in the colon or ulcers as a source for this blood loss. So one of the classic internal medicine board questions is, if you have a patient with iron deficiency, an 80-year-old man with iron deficiency, what's the next step? The next step is always endoscopy, colonoscopy. So there are a few things we look for in iron deficiency. We can actually measure iron studies in the blood, but we can also look at the blood. Here is a normal blood smear on your right, on your right. These big cells here are white cells. Those are called neutrophils. But most of the cells in this field are red cells. And you can see that there's a relatively round or oval-like. And in the middle, there's a little bit of clearing, and we call that central pallor. On the left side here is iron deficiency. It may be hard to appreciate, but these cells are smaller than these cells. When you're iron deficient, your cells get smaller. And that's something we look for on the CBC. What may be easier to appreciate is that there's more central clearing. And that's a very good sign of an iron deficiency. There are some other things that cause the central clearing, but we really think of iron deficiency when we see the central clearing. And this is why your doctor wants to draw all those tubes of blood, and a good hematologist will always look at your blood under the microscope. Now, when someone has iron deficiency, he or she will present with symptoms of anemia. We've gone through those, but again, those are fatigue, pallor, a fast heart rate. Importantly, some of these symptoms may be relatively subtle, and it depends on how quickly the anemia has occurred. If someone was born with anemia, for example, through a genetic cause, thalassemia, he or she may not have any of these symptoms or may tolerate these symptoms very well. Whereas if anemia occurs rapidly over a matter of days or weeks, the person is going to feel this much more abruptly and to a much higher degree. Essentially, the body can adjust to anemia over time. So in fact, anemia may be asymptomatic, and you may go to your doctor for your yearly checkup, and the doctor used to say, listen, your hemoglobin used to be 13, now it's 11. Your cells used to be big, now they're small. I think we should check iron studies, and maybe you should go on iron. And if you're older, postmenopausal, or a man, your doctor should also say, I think we should look for any source of blood loss through your bowels. Interestingly, one thing that's, so when I was a medical student, we had a very proper hematologist who spoke with an English accent, even though he wasn't from England. He was from New Jersey. And I remember seeing a patient with him, a patient who had iron deficiency. It was a pregnant woman. That's very common to get iron deficiency in pregnancy. And he said, young lady, have you been chewing on ice? And she said, oh my God, how did you know? You're brilliant. But in fact, chewing on ice, chewing on uncooked starch, sometimes chewing on clay, that's known as pica. It's a very common symptom associated with iron deficiency. No one really knows why, but that's just an association that's well noted. Of course, the next patient I saw with iron deficiency, I asked her the same thing, have you been chewing on ice or starch? She said, what, are you crazy? So it doesn't work for everybody. Iron replacement is very simple and very inexpensive. It's iron pills, 325 milligrams up to 3 times a day. Again, you absorb 1 milligram, but not all of this is elemental iron. Absorption is increased by gastric acid, so if you're on a Nexium proton pump inhibitor, H2 blocker, Zantac, you may not absorb it as well. And I often ask patients to take their iron pills with vitamin C or with orange juice. For people who don't absorb iron, and there are some people who really don't absorb iron, people with celiac sprue and other conditions, people who've had bypass surgery, a bariatric bypass surgery, sometimes we give intravenous iron, which is relatively safe, not so convenient though. Vitamin B12 deficiency is another cause of anemia. All the B12 is produced by bacteria. Usually it's done in the colon. bacteria in the colon make B12, and B12 is absorbed into the bloodstream through a part of the small bowel called the terminal ileum. So there are people who have their terminal ileum removed, who've had surgeries, and sometimes those patients become B12 deficient. Meat, liver, eggs, and fish contain B12. You have about a 3-year supply in the normal liver. And this is why before we gave B12, before we knew about B12, liver was a great way of curing anemia because some of that anemia was B12 deficiency. So that's why you may hear people say, eat your liver if you're anemic. If you're B12 deficiency, sometimes it can cause severe anemia. Sometimes it can be mild. But often the first hint of B12 deficiency is through an anemia. And that's very important because B12 can not only cause anemia, but can also cause neurological symptoms. So it's very easy to fix through B12 shots or even B12 pills. And it's very important that we pick it up. And one of the ways we can pick it up, if we look again at the blood under the microscope, and this takes about 20 seconds to make a smear and look at it under the microscope, is the cells get bigger than normal. So here is a normal red cell, and you can see right next to it is a very big red cell. And that can be a sign of B12 deficiency, and there are other signs in the blood of B12 deficiency too. Now, erythropoietin. So remember I said you need iron, you need B12 and folate, and you need erythropoietin to make red cells. Erythropoietin is a hormone made by the kidney. And erythropoietin levels go up when someone's anemic or when they have, for any cause of low oxygen in the body. So for example, if you travel to a high altitude, a very high mountain, and the body is not getting enough oxygen, your body will make more erythropoietin and your blood count will go up. Your red cells will increase in number. People who don't get enough oxygen because there's lung problems such as COPD, sleep apnea, that can cause erythropoietin to go up and cause increased red cell count. Now, if you don't have erythropoietin, and the most common cause, in fact, almost the only cause is renal insufficiency, oftentimes due to diabetes. If you don't have erythropoietin, you will get anemic. So you may know about erythropoietin because many athletes, particularly endurance athletes, cross-country skiers, bicycle riders, have all been found to be doping with erythropoietin. We have EPO, we give it all the time. It's a drug called Procrit, Aranesp. It can replace EPO. It can increase the red cell count when someone has low EPO. It can even increase the red cell count for other diseases causing anemia. So we give a lot of erythropoietin. Over the last year or two, it's been found that erythropoietin has some bad consequences that no one had really appreciated initially. So we use it a little more sparingly now. We only use it for certain conditions. We watch it very closely. But erythropoietin can really be a great drug to increase the red cell count, particularly if you're erythropoietin deficient and that's the cause of your anemia. And that's usually, again, from kidney problems. Now, so we did low iron, we did low B12, and we did low EPO. Towards the end here, we're coming to an abnormal bone marrow. So when you have an abnormal bone marrow, typically you don't make red cells, and you also don't make white cells, and you also don't make platelets. The abnormal, but sometimes you can just not be making red cells, or that can be the most severely affected type of blood cell that's not made. An abnormal bone marrow can come from scarring, or what we call fibrosis. That can be specific diseases that cause just scarring in the bone marrow. It can be from a group of conditions called myelodysplastic syndromes, and we'll talk about this a little bit more, where your red cells are not maturing the way they should. Or it could be because you have a condition called aplastic anemia, where there's an attack against the red cells in the bone marrow, so nothing grows up in the bone marrow. So this is myofibrosis. It's a little hard to appreciate, especially if you don't really know what a good bone marrow looks like. But believe me, there's a lot of scarring in this bone marrow, and when there's scarring, you can't, your bone marrow cannot make red cells. And on the peripheral blood smear, we see these little teardrop forms, and that's a good sign that there's scarring or there's something packing the bone marrow. Red cells normally differentiate. They start off as very immature cells, just as kind of baby red cells, and they grow up, they grow up, they grow up, till they come out of the bone marrow. And when someone has a condition called myelodysplastic syndrome, the red cells don't grow up the way they should. And the white cells also, and the platelets usually don't grow up the way they should. And there are several features we see under the microscope that suggest someone could have myelodysplastic syndrome. These are not great pictures here, and it's a little subtle for the untrained eye, but a good hematologist can see that these cells on the right here are not normal. They don't look the way they should. They often also have a lot of problems with their DNA. So one of the things that doctors can do when they're looking at your bone marrow is spread the bone marrow cells on the slide and get the DNA out of the cells, the chromosomes out of the cells. We know we have 46 chromosomes, 23 different chromosomes in duplicates. And you can see here, as they're laid out, so these are actually strips of DNA which code for your genes. But here, where the arrow is pointing, you're missing, this person is missing a little bit of chromosome 3, missing a little bit of chromosome 4, has a little bit of extra of chromosome 6. So this is damage to the chromosome, damage to the DNA that is often seen in myelodysplastic syndrome. And so cells are not growing up the way they should in myelodysplastic syndrome. When it's very severe, they don't grow up at all. And that's where you see this type of cell, which is a cell we don't like to see. On the right, this is a leukemia cell. It's called a blast cell. They're bigger than normal cells are here. To me, they look ugly. And this is when we have to give chemotherapy to someone with leukemia here. The cells just aren't growing up. That causes anemia too. Then finally, this is what I talked about, aplastic anemia. Here's a normal bone marrow on the left where you have lots of cells growing in the bone marrow. With aplastic anemia, either because of chemotherapy or often because of an active immune system that fights the bone marrow precursor cells, there's an absence of cells in the bone marrow. And obviously, someone will have anemia because of this. Now, there are many causes of rapid destruction or consumption of red cells. I'm just going to go through a few of them. This is sickle cell anemia, which you may have heard about. Many people have sickle cell anemia, and this is actually, just looking at this slide, this is not my slide, someone gave it to me, but the person probably has a form called SC disease. And these cells, you can see this one is classic, looks like a sickle that you would cut wheat with, I guess. And these cells do not last. The normal red cell lasts for 120 days in the bloodstream, but because of the shape and other features of this, the cells last much shorter. So someone often has anemia because the cells aren't lasting as long as they should. Here is immune-mediated anemia, and we often see this. This is when someone will turn yellow in the eyes. Many of these destructive forms of anemia will cause yellow eyes, brown urine, because the cells are actually being broken up in the blood. This is caused when antibodies, we all make antibodies usually to fight infections. Sometimes in autoimmune disorders, antibodies fight our own bodies. So autoimmune thyroid disease, you can become hypothyroid. With autoimmune anemia, the antibodies land on the red cells and cause them to be destroyed. And particularly these very small red cells, perfectly round here, are the cells that are being destroyed. The antibody lands on the red cells and plucks off some of the membrane. And that's why these cells are smaller and don't have the central pallor. And then finally, malaria, which may not be so common here, but is extremely common in other parts of the world. You can see these little, in a red cell, you see these little inclusions here. Those are actually malaria parasites, and they can cause destruction of the red cell too. So sometimes we even pick up malaria when we do a blood smear. So just in summary, I know that's a lot of information. You're not expected to go out and treat your neighbor or diagnose your neighbor with anemia. But hopefully what I've told you, what I've let you know during this talk is that anemia is not just iron deficiency. It's many, many, many different conditions. And that can include those conditions which interfere with iron absorption, B12 or folate, erythropoietin, and you also need a healthy bone marrow. So a hematologist can typically find the cause of anemia, fix the anemia with a good history physical exam, and of course lots of tubes of blood. Okay, thanks. So now I think Bruce, Raphael is going to come up and tell you when you can't fix the anemia, simply other ways to fix anemia and other blood